Morning, I'm Dr. Sheehan from Sheehan Natural Health Improvement Center, and today we are going to talk about iron deficiency and anemia. This is a relatively confusing topic. There's a lot of confusion on this. I've never seen a patient come in that knows the difference, and in fact, I've often heard doctors talk about them in the same sentence. And they can be used in the same sentence, but they're not the same. So let's go over this because this is very, 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 very important. I'm making these primarily for my patients, but also patients out there. Because if you don't know the difference, you can get into trouble. So let's explain to you why. Okay? There is a difference. There's iron deficiency. Okay? About 1/3 of the population of the world is iron deficient. We don't have enough iron. Okay? A lot of the world actually has a condition of scarcity. In our country, U.S., we have too much of just about everything, and we end up with problems from food to, I hate to say it, but in certain cases, money, stuff to do, time online, all that kind of stuff, just way too much everything. But the rest of the world, 1/3 of the population actually has iron deficiency. And so that's iron deficiency, okay? When we're talking about anemia, we're talking about low hemoglobin. Now, hemoglobin is the protein in our blood, in our red blood cells, that actually carries oxygen, and it relies on iron, okay? So a lot of doctors and patients, they put the two together and they say, okay, well, if you have low hemoglobin and you're anemic, that means you're iron deficient. And that's not the case. There is also a sizable number of people that have what's called anemia of chronic inflammation, anemia of chronic disease, anemia of chronic infection, okay? And they are different. What happens is if you have chronic inflammation or chronic infection, you can end up being anemic, but you can actually have high iron, okay? If you give these people iron, you can make them much worse. So I'll give you an example. I have a patient that came into my office, and he asked to have all his labs looked at the other day. This gentleman is older, much older. He's in pretty good shape for being older, and he is a super nice guy. And he says, I want you to look at my blood test to see what vitamins and minerals I need to be taking. And I was like, cool. So I look at him, and he comes in, and you can tell from his diet that he's actually eating way too many carbs that turn into sugar, and so it's throwing off his biochemistry. And it's causing chronic inflammation, and he also has a chronic infection going on, most likely in his bladder, because it shows up in his urinalysis. And from the chronic infection, chronic inflammation from the diet, he actually has inflammation, and he ended up being anemic. Well, his doctor saw that and said, you must be low in iron, and so he gave him iron. When this patient came in, his iron levels, his ferritin, which is an iron storage protein, but it's also a marker for inflammation, was like off the charts, okay? And so for him, his proper course of action was to actually decrease the inflammation, decrease the infection by getting on the right diet, which is the PAGE diet we're going to go over in a second. And also, I sent him back to his doctor. As a chiropractor, natural health practitioner, we're not supposed to cross what the doctor said, but I said, go back and bring these lab tests to your doctor so you can show him that actually you have too much iron, and so maybe he can reassess whether or not you need this extra iron. Incidentally, I don't think his doctor ever did actually assess for iron. They only checked for hemoglobin. So they're two separate things. But we see that all the time, okay? So that's my little story. Let's go over first. There are actually 3 stages of iron deficiency. This is very, very important. The first is when your stores actually get depleted. This is when you don't have your stores topped out. They go down to here, okay? If they keep on going, okay, then you end up with mild iron deficiency, which shows up in your markers, okay? If that goes on too long, then you end up with anemic. So when people come in here into the office, okay, and if they have iron deficiency and anemia, okay, it means it's been going on for a long time, okay? And the big problem with having iron deficiency and anemia is that if you have anemia, okay, you're not getting oxygen to your tissues. Just try holding your breath for about 2 minutes and you'll realize that everything becomes more painful. You can't think, everything. You're not getting enough oxygen to your tissues. That is very, very bad. You need to get plenty of oxygen to your tissues. That's why it's such a dangerous problem. Okay? Well, let's go over the signs and symptoms of iron deficiency. First of all, you've got fatigue. Notice with anemia, you've got fatigue. This is part of the reason for the confusion, is they overlap a lot. We've also with iron deficiency, you've got a weakened immune system. Iron is used by your immune system amongst other biochemical pathways in your body. And so if you don't have enough iron, your immune system will get weakened. Okay? You will have thyroid stress. A lot of people say that I have thyroid stress. I had one woman come in here and she was crazy hyperthyroid. And a number of people actually have it like that. And when we did her iron assessment, I saw that she had iron deficiency and anemia. And I said, did you know that you have iron deficiency anemia? And she said, yeah, I've been iron deficient, and I had anemia for my whole life. And I said, did your doctor ever correct you? She said, no. I was like, well, that will greatly increase your risk for hyperthyroidism and hypothyroidism. Okay? You will also have a lot of people with anxiety. You'll have a lot of people with depression and insomnia. By the way, I have found that a lot of people that have anxiety, depression, and insomnia, okay, they have some kind of nutritional deficiency, either vitamin, mineral, and some kind of organ imbalance. A lot of people have anxiety, depression, and insomnia because your body functions without you thinking about it. Think about it. All right, your heart rate, okay, you don't control that. Your respiration rate, I mean, you can think about it, but it just kind of happens without you thinking about it. Your digestion, all these things happen without you thinking about it. Also, your body has a self-righting mechanism where it corrects problems inside, okay? And what a lot of anxiety, depression, and insomnia is actually your body knows that there's something wrong, and it's actually giving you a sign. And it's actually looking for those things. You know how we have people that have repetitive thoughts? What's happening a lot of times is your body is intuitively looking for what's wrong. I know that I've never heard that said before, but when people come in and you fix their vitamin mineral deficiencies and their organ dysfunctions, a lot of times anxiety, depression, and insomnia get better. Unless, of course, you have an anxiety, depression, insomnia because there's something in your life that you're not taking care of. You're not doing something that you should be doing, or you're doing something you shouldn't be doing. Let's say you're getting beat up by your job and you know you should be quitting. That can cause anxiety, depression, insomnia. Let's say that you're in crazy amount of debt because you're overspending your credit cards. Okay, you shouldn't be doing that. That'll cause anxiety, depression, insomnia. But otherwise, a lot of times we see nutritional factors, vitamin mineral deficiencies, and then organ dysfunctions. That's really important. Anemia, we have, like I said, we have some overlap. We see the fatigue. We also see weakness. We also see dizziness. Sometimes people will feel dizzy, and their doctors will say, well, maybe you have anxiety. So that's the overlap there. We have high heart rate. Some doctors will be like, oh, you have high heart rate? You must have anxiety. This is the overlap again, okay? Pale skin, not as much overlap. And mucous membrane that are pale, okay? These are the symptoms. What I can tell you is that when people have iron deficiency and anemia, they have basically their program, we put people on a nutritional program, diet, exercise, supplementation, and stress reduction. They don't get better unless you fix this. It's actually pretty easy to fix too. Okay, now, can you zoom in on that or no? A little bit. We're going to have a separate chart for this. Jen's going to put it in there. Jen is the host behind the camera, and she's awesome. But she's going to put a link to this below. Okay? So, now remember, I don't expect you to diagnose yourself. In fact, we don't do diagnosis. What we do is assessment. Okay? You go to your doctor, your medical doctor for diagnosis, and then usually what they do is they give you drugs or surgery. Okay? There's not any drugs for anemia except for they give you iron, and so usually a lot of times people aren't even treated. They don't even check for it properly. Okay? But these are the things that we look for iron deficiency. Okay? Notice these markers over here. you usually don't see these on a standard lab panel. Okay, we check every single patient for them though. Okay, we've got the TIBC, total iron binding capacity, UIBC, unsaturated iron binding capacity. Sometimes they have different words for these, and it depends on who you look at, because of the fact that they mean the same thing. Basically, what these mean is how much room do you have for your ability or for your body to store iron. Okay, that's what these ones mean. Percent transferrin saturation. Transferrin is the primary molecule in your body that your body uses to transport iron. That's why it's called transferrin. Okay, the transferrin saturation. Now these numbers up here are storage. So the less storage, the lower the numbers, the lower the number, the higher the iron, and also the higher the number here, the less the iron. Okay, it's what's called an inverse marker. Let me put a little. I'm going to put inverse marker. Okay, those two are inverse markers. Okay, so like I said, the higher the TIBC and UIBC, the lower your iron. Okay, remember, I don't expect you, there's not going to be a quiz on this biochemistry. Just understand that when you look at your labs. Okay, so functionally low iron. I remember we have another video on the functional lab reference ranges versus standard lab reference range, and Jen will put that below. But basically, you want to be in the functional reference range. The functional reference range is like the healthy reference range. The standard lab reference range is just an average of people. You want to be in the healthy, okay? But you'll have low iron, okay, if your TIBC is over 425 and your UIBC is over 343. Then we've got what's called a transferrin saturation. Now this is what's called a direct marker. In other words, the lower this is, you tend to have less iron. The higher it is, you tend to have more iron. Remember why I say tend? The reason being is that we always look at things in correlation to other. There's 5 markers here, and so you should see a very clear correlation. In other words, they will all show towards increase or decrease. If one is out of range, that doesn't really mean much. These are direct markers down here. Whoops. Wow, I'm really messing this up. Okay. Is that clear, Jen? Does that make sense? Okay. So the transferrin saturation, the standard lab reference range is 15 to 55. The functional reference range is 25 to 30. You want tight regulation of your iron. Okay. If you have less than 25, you tend to have too little iron. If you have more than 30, you tend to have a little bit too much iron. Okay. But remember, you read these in correlation with the other 4. Okay. You have the serum iron. Okay. The standard lab reference range is 38 to 169. The functional is 40 to 135. You tend to have low iron if you have less than 40. And then you have ferritin. Remember, I went over this in the iron overload class, but ferritin is what's called a dual marker. Okay. Dual marker means it tests for 2 things. Okay. It tests for inflammation and iron storage. So this is where it gets tricky, and this is where we're going to go over a little bit of anemia of chronic disease and chronic infection and chronic inflammation. But the standard lab reference range is for women 30 to 200, men 30 to 400, and that differs according to each lab because remember I just said it's an average, has nothing to do with health. However, the functional lab reference range is pretty static. In other words, experts mainly agree on this. It's 30 to 70 in women and 30 to 100 in men. If you have less than 30, you are tending towards iron deficiency. Now, remember, we went over this. Did we do the iron overload one last week? We did the iron overload, right? Okay. So in iron overload, these numbers tend to go, the transferrin saturation, serum iron, and ferritin, they go up, okay, over these numbers right here. And the TIBC and UIBC go down. The thing to keep in mind, though, and we're going to go over this in a second, is that let's say that you have, like that elderly gentleman that came in the other day, he had high ferritin, very high ferritin, because he had inflammation and he had too much iron, okay? But you will see people that have infection, that have low iron, but they have high ferritin. So it's a little bit confusing, Honestly, if you have questions about this, I would recommend that you see a functional medicine doctor. You can bring the labs. You can call our office, okay, and we can order them for you. All sorts of things. There's lots of resources out there. Okay, we have another video on how to find a functional medicine doctor, so I would look at that. If you bring this in, I have seen this before. We are not anti-medical. However, I have seen patients bring their lab work to medical doctors and they will misread these. Okay, so just keep that in mind. A lot of them are not in the know with iron storage because there's no real drug treatment for it. And so they kind of ignore it a lot. Okay, just keep that in mind. I'm not saying they all do, and I'm not, throw them all under the bus. It's just that typically they tend to look at things with drugs and surgery, and so that a lot of them will miss this. If you're one of the medical doctors that actually looks at this, thank you. Okay, okay. And then we have, so that's the iron deficiency, and then we have anemia down here. Notice that we use, so basically you want to look for iron deficiency first, okay? So always look for that first. And then we have down here, which is for anemia. Notice these are completely different markers, okay? Iron deficiency up on top, anemia down and below, okay? And really what we have here are the different, the different indicators of anemia. We've got red blood cells, the number of red blood cells. We've got hemoglobin. Remember that the oxygen transporting molecule that is based around iron in your red blood cells. Hematocrit, which is basically the packed cell volume. Okay, in other words, how would you say? It's like the proportion of red blood cells in the blood. Okay, then we've got what's called mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration. These three numbers talk about how much hemoglobin is in each cell, okay? And so obviously, if you see less red blood cells, less hemoglobin, less hematocrit, and then less this is what's called the mean corpuscular volume, which basically corpuscle means cell. And so mean means average. So you have an average small cell size, okay? Which means that you're going to have less hemoglobin. Mean corpuscular hemoglobin, that's the hemoglobin inside the corpuscle, inside the cell on average. That goes down. And then you've got mean corpuscular hemoglobin concentration. Such a mouthful. But basically average hemoglobin in each cell concentration down, okay? So you're looking for all these to go down when you have anemia, okay? The only one that tends to go up with anemia is what's called the RDW. That's called the red blood cell distribution width. And what happens is when you're anemic, what happens is your body starts pumping out all sorts of cells to try to make up for that deficiency. And basically, the lower the red blood cell distribution width, the more regular size these red blood cells are. The higher that number, okay, the more irregular their size is, which means that your body is trying too hard. That's a way to look at it. You want this number less than 13. In someone with iron deficiency anemia, you're going to see it like 14 or 15 usually. And these are the marker numbers right here that you're looking at. Okay, remember, with iron deficiency anemia, they tend to all be low. By the way, the more of these that are low, the worse that it is. Common sense. You're also going to see red blood cell, hemoglobin, and hematocrit go down or decrease before the mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration. So these top three go down before these bottom three, okay? But the RDW with iron deficiency should always be a little bit higher. And like I said, it'll be over 13, usually 14 or 15, okay? I know that's very confusing and very technical, but like I said, I don't expect you to actually read these, but you should know the information so you can bring it to your functional medicine doctor. Or if you've come in to see me, okay, and you're like, I want to show my family about this. Cool, go ahead. It'll make a little bit more sense then, okay? All right. So, How to improve blood markers for iron deficiency and anemia. Okay. Number 1. Remember that this is, we deal with this, we have 13 categories, okay? And this is category 4, the iron deficiency and anemia. You've got other ones below that. You can look at our series. But the first thing you do is you handle food sensitivities. There are all sorts of different ways to do this. I will tell you that I have seen the best way to do this is what's called with the page diet. The reason why I say, in my observation, I do pre and post lab tests, so I see improvement. Okay, I have not seen as much improvement with the other diets out there. Keto, intermittent fasting, paleo, all those types of things. They're all better than the standard standard American diet, the SAD. However, they do not do as well as the Page Phase 1 or 2. Page Phase 1 or 2, we have another video on that. Take a look at that. But basically, Dr. Page found this diet by giving people things to eat and then testing their blood up to 3 to 5 times a day and seeing how the biochemical changes happen. It was incredible. He has thousands, okay, of readings on people. Okay, he died a long time ago, and this is a very old diet. It is a predecessor of the keto diet, the paleo diet, South Beach diet, all those types of things. So, handle food sensitivities by Page Phase 1 or Phase 2. Look at the Page diet. Basically, you do Page Phase 1 if you've got a blood sugar problem, Page Phase 2 if you don't. Try to incorporate 2 ounces of liver 2 to 4 times a week. Also, clams and oysters are good sources. They are much more expensive, and that's why I say liver. Some people cannot stomach the liver. Find a good liver recipe. I would recommend it. I've seen people do tremendous improvements just incorporating liver into their diet. Besides being very high in iron, it's also high in zinc and copper. And those 3 minerals exist in a specific proportion in your blood, in your body. And so even if you have too much iron, if you eat liver, it doesn't tend to raise your iron because it's got balanced levels of copper and zinc. That being said, with the added copper and zinc in there, it also balances out your immune system, your hormones, all sorts of things. It's good for everybody. Okay. Low iron, we give a supplement called Ferrofood from Standard Process, 3 to 6 per day. If people are really severe, sometimes people test for 9. We use what's called muscle testing from nutrition response testing, and we can dose people. But if you don't have that, 3 to 6 per day will work. If they're low iron with anemia, okay, then we add something called chlorophyll complex. Remember I said that the hemoglobin molecule, basically in plants, if you have the hemoglobin molecule but you put magnesium in the center instead of iron, you have chlorophyll. So if you take Ferrofood for the iron deficiency and the chlorophyll complex, basically for the hemoglobin molecule, it's almost like someone said, it's like a blood transfusion. I mean, people rapidly improve. Okay, and I've used this for people that were very symptomatic, and within like a week, they feel so much better. So we use about 3 a day. If macrocytic anemia present, also include cataplex B12, 6 per day, and or folic acid B12, 6 per day. That B12 is missing off there. So that's what we do for that. We're going to have another presentation, and the link is going to be down below, in the assessment of B9 and B12, where we talk about macrocytic anemia. Okay, that just means, macro means big anemia, so big cells with little bit hemoglobin. The primary thing that does that is B9 and B12 deficiencies. Hypothyroidism can also do that, but primarily B9 and B12 deficiencies. Okay, and the way that will represent, by the way, we'll give you a sneak peek. Let me see this. Okay, macrocytosis, which means that basically what's called the mean corpuscular volume. Okay, that's the size of the cell. That will be big, but these indicators up here will be lower, and the RDW will be higher, just like in iron deficiency. Okay, so if you see big cells with little bits of hemoglobin, that's called macrocytic anemia. Whoa, I knocked that out of place there. You still see it properly? Okay, all right. An anemia of chronic disease. Remember, I said that if the person actually has anemia, but they have if they have anemia, okay, remember this stuff is low. These tend to be low, except for the RDW, which tends to be high. And these ones, the TIBC and UIBC, can be low. The transferrin saturation, I'm sorry, this is a little bit confusing. But basically, if you see ferritin sky high, okay, and the rest of the markers point towards iron deficiency, you want to basically find what's causing the infection and or the inflammation and fix it instead of giving iron. You can actually make them worse, okay? Like I said with that elderly gentleman the other day, he was anemic, but his ferritin was sky high. And so what I did was I said, well, where's that inflammation coming from? It was coming from infection and poor digestion and the wrong diet for him. He was just eating too many carbs. It wasn't bad food, it was just too much for him, okay? And so we fixed that instead of saying, okay, now I'm going to give you iron because that'll make him worse. That'll make more inflammation. And then what we do is retest 2 weeks before a reevaluation. If you're not a patient, what I would do is go with that protocol, and then you retest every month. It should improve every month. Okay? Hopefully, that gives you a little bit of information on iron deficiency and anemia. Like I said, I don't expect you to completely understand it, but this will give you enough information so that now you can go to your functional medicine doctor and explain these. Okay?